of activities actually. I have a lot of words to speak about him, but due to the time, we'll proceed for this important session about CKD-associated anemia. And I hope that we have interaction as usual with Dr. Hussein to get more benefit. Okay, Dr. Hussein, please.
Anemia and chronic kidney disease. This is one of the big chapters in the management have to manage, and a lot of questions will be answered through the presentation. I tried to simplify as I can, so I omitted 50% of the slides, and I left 75 slides. So this is why, because my focus today is to give you an idea about what is the definition of anemia in chronic kidney disease. Is it different from general population? Actually, yes. How we diagnose anemia in chronic kidney disease? This is the first sector. Is it associated with outcome, without? So what is the impact of anemia in chronic kidney disease? I'll answer this question too. Then I'll summarize the treatment strategies that we have in the management of anemia in chronic kidney disease. Principally, iron therapy, and then ESA. ESA means erythropoiesis stimulating agent, because we have short, intermediate, and long-acting drugs belonging to this group. Is not only erythropoietin as we are accustomed to say. Then, few words about if we treat the patient with this class of drugs and the patient doesn't respond, the question why the patient doesn't respond to the treatment. This is another practical and important question. And then special issues, and one of the important points, we are treating anemia to reach what target? What target of hemoglobin we see, and then I'll end with the case. To start with, this is one of the 74 slides. This is your photo in the urinary tract at the outpatient clinic today. So my question to you, what is the definition of anemia? What's your expectation of anemia in chronic kidney disease? Yes, please, I want you to interact. Please. What's the cutoff point of hemoglobin to diagnose anemia in chronic kidney disease?
So somebody will answer, please.
Yes, please. What? 6? 12? Less than 10. Any other values? Yes? Yes. So if we speak about adults.
It depends on the age.
Adults.
For adult, it depends on sex.
Yes.
For the female.
And if you have adult female, what's the cutoff point? And I am afraid that you will say it depends upon the number of limbs. Okay, you are right. And this is a table of the National Institute of Clinical Excellence that was reviewed last year. So these are the different ages and the gender. If you are dealing with the children, if hemoglobin drops below 110 gram per liter or 11 gram per deciliter, this is anemia. 6 months to 5 years, 11.5. 5 to 12, 12 gram per deciliter. Non-pregnant females, above 50 years, 12. males, I can't say pregnant males. So males, if below 13 gram per deciliter. We should discriminate between two issues: the cutoff point for diagnosis and the indication for treatment. Here we have two different targets, because if I diagnose anemia in a adult male, when I find the hemoglobin is 12.5, I will not give him erythropoietin. But I search for iron deficiency. If I find iron deficiency, I give him iron therapy. That's all. So there is a difference between the cutoff point of diagnosis and the treatment strategy and the target for treatment. Okay? So this is the answer of the first question. Yes?
You have here an important point about living at sea level. Also,
Yes.
it's important to be considered in patient and high altitudes to be different the definition of anemia. And so also you mean this is general.
Yes,
population
general,
and
yes.
not specific.
Yes, you are right, because as you know, even here in our clinical practice, Egypt is not high altitude. But whenever I stay in the outpatient clinic, and then I looked at hemoglobin and I find 17 gram per deciliter, I know that this male or female is a smoker, because smoking is a hypoxic issue that may increase hemoglobin. So you are right that there is individualization, but this is a common values of hemoglobin to diagnose anemia. From the lessons from this study, it shows that the doctors are aware of anemia and they are eager to use ASA therapy to diagnose chronic kidney disease associated anemia, and they usually neglect iron. Although iron is cheap, and if we use ASA therapy to treat anemia, erythropoietin to treat anemia, and the patient has iron deficiency, the patient will not respond to erythropoietin properly. So we should be aware of anemia, and we should know that we have strata to go, or steps or algorithm to follow. So the algorithm is to satisfy iron and then to think of ASA therapy. This just to show you the importance of anemia. Here I have 4 patients, anemia only, and this is a survival of anemia only. And here, anemia and chronic kidney disease. What you find, if anemia is added to chronic kidney disease, survival is affected. Okay? And here as well, anemia can affect the transplant outcome in adult, children, and this is one of our publications. So, as you see in these slides, we should control anemia, because controlling anemia improves quality of life, improves exercise capacity, decrease high output failure, improve ischemic heart disease. One of the strategies to reduce left ventricular hypertrophy. Controlling anemia improves bleeding tendency. And this is one of the questions. Why? If I improve anemia, this will improve bleeding tendency. Why? How to think of the answer of this question? Why control anemia has good impact or good effect on bleeding tendency? Because to have a well-functioning platelet, because platelet and vascular element are within the primary defense mechanism against bleeding. For the platelet to form the blood, you should have red cells, because red cells push platelets to allow the function of platelet to be in a good manner and to release von Willebrand factors and to plug the bleeding hole. So we need to control anemia for the controlling bleeding. Today we have obstetric presentations, and for the general knowledge, if we have anemic lady, anemia will increase the risk of antepartum and postpartum bleeding. So anemia can lead to bleeding and increasing bleeding tendency. Anemia control improve cognitive function, decrease or improve depression, improves sleep patterns, improves sexual function, improves endocrine function, improves immune function, improves muscle metabolism, it decreases hospitalization, and this will reduce the cost, decrease the need of blood transfusion, and this is by its own, it is a goal for us to avoid blood transfusion, because we don't know in the future how many organisms will be discovered to be transferred by blood, and improve the nutritional status of the patients and improve the appetite. So we should control anemia. Here I don't say to normalize hemoglobin. I just say to control anemia, and this is what we will work in the following sectors.
That's why you have to treat anemia. Most of the symptoms the patient exposed in CKD is related to anemia. So if you treat anemia, you treat a lot of symptoms of the patient. So anemia itself is not a target. You are treating the patient through the anemia.
Thank you very much, Professor Ahmed, for this note, for this comment, because the majority of symptoms that we may say or assume that is because of uremia, it is anemia-related symptoms rather than uremia. So control of anemia is very important and crucial. My question now, what if I want to control anemia properly? I should know the potential or the pathogenic mechanisms. In a practical way, in chronic kidney disease, erythropoietin deficiency is one of the causes, because this is a question for you. At what level of estimated GFR erythropoietin production decreases? 90 milli per minute, 60 milli per minute, or 30 milli per minute? 90, 60, or 30? If estimated GFR decreases below 60 milli per minute, the secretion of erythropoietin starts to decrease. So erythropoietin secretion decreases from the early phases of chronic kidney disease. For your information, in utero, the main source of erythropoietin is the liver. And after delivery, after birth, there is a shift in the factory of erythropoietin from liver to kidney. So the kidney is the main organ which is responsible about the erythropoietin production, and this is one of the hormonal function of the kidney. When the kidney function drops or decline, secretion of erythropoietin decreases. Then the best strategy to think of the pathogenic mechanism is to put in your hand what are the easily correctable factors that if I think of them and correct them, what will happen? Anemia will improve. So these are, as you see in this slide, absolute iron deficiency, vitamin B12 and folate deficiency, hypothyroidism, the use of angiotensin converting enzyme inhibitors, or angiotensin receptor blockers, or non-adherence to the anemia management. So if I find any one of these factors, I can modify. And always I like the factors or causes to be classified into modifiable factors, partially modifiable, and I will not care about non-modifiable because I cannot change the gender from male to female or the age from old to young. So these factors are important to be thought and to be corrected. Other factors are potentially correctable, include infection. So I should examine the patient properly and eradicate infection, any infection I find. Under dialysis, if the patient is on dialysis, optimization of dialysis or delivering adequate dialysis is one of our job. It is mandatory to offer an adequate dialysis. And then searching for causes of hemolysis and dealing with bleeding. Sometimes the patient has hematemesis, melena, etc. I should control bleeding, managing hyperparathyroidism, dealing with malnutrition and malignancy. So these are some potential correctable factors. So I should think of this and this column. But if I have these factors which are impossible to be corrected, but I know the diagnosis, if I am dealing with hemoglobinopathies or bone marrow fibrosis, what can I do? So my treatment strategies are very limited to support the patient by blood transfusion, etc. Because if you have bone marrow failure or bone marrow fibrosis, the patient will not respond to erythropoietin. So this is the map of the causes. If I know it is absolute iron deficiency, I should give iron. So starting with anemia management, start with iron, and iron. And then, and it is cheap, or relatively cheap. And then I think of erythropoietin deficiency. And I give the least possible dose. If the patient needs a larger dose, I should think of the causes of erythropoiesis resistance, as I showed you. So the first stop in the management is iron. And this is the last update of the guidelines in June 2015, showing all these definitions. My question to you, what are the types of iron deficiency? We have absolute and functional iron deficiency. What is the difference between absolute and functional? How can I diagnose absolute iron deficiency? How? Is it by measuring ferritin or transferrin saturation? You, male or female?
Transferrin saturation.
He mentioned ferritin, transferrin saturation.
Yeah.
Who think of other diagnostic modality? Ferritin. You say ferritin, and he say transferrin, male and female. According to the new guidelines and the practical strategy, neither serum ferritin nor transferrin could work on. So what can I diagnose? How can I diagnose? By both of them. This is the least acceptable diagnostic strategy for absolute iron deficiency, to know the level of ferritin and the level of transferrin saturation. And this is the minimum. The best is to measure the level of hypochromic red cells. If it is above 60%, this is a sure, this is better diagnostic strategy for absolute iron deficiency, followed by reticulocyte hemoglobin if it is less than 29 picogram per ml. If I don't have the ability to have capability of this test, neither the hypochromic red cell or reticulocyte hemoglobin, I'll depend on the practical available parameters, which are transferrin saturation and ferritin. But I should measure both of them. And then I consider if ferritin is less than 100 and transferrin saturation less than 20%, this is a case of absolute iron deficiency. So absolute iron deficiency is diagnosed if ferritin is less than 100, and this is in chronic kidney disease, not in general population. Because in general population, ferritin is quite lower than chronic kidney disease. In chronic kidney disease, there is a level of low threshold inflammation. This is why we say ferritin is 100. So for diagnosis of absolute iron deficiency, I should measure both ferritin and transferrin, which are available in our countries. Okay? But from the guidelines and from the literatures and from the science, hypochromic red cells percentage is superior to ferritin and transferrin saturation.
Just I want to mention that we can't depend on ferritin alone because we consider it as one of the acute physical.
Yes, this is why I'm stressing on both of them, because sometimes, and this is why I didn't stress on this point, because I stress it when I discuss the functional iron deficiency. In functional iron deficiency, I can find higher ferritin, but lower transferrin saturation. So if I find ferritin, for example, 500, and transferrin less than 20, this is a state of functional iron deficiency related to inflammation. And I can diagnose this functional iron deficiency by measuring hepcidin, this cytokine. I'm not going to discuss with you any advanced knowledge, because hepcidin up to this moment there is no clear guidelines to measure it. It is a cytokine released from liver. This is why it is HEP, and it decreases the bioavailability of iron. So it blocks the iron absorption from the gut and blocks the release of iron from reticuloendothelial system. So it opposes iron. And if it is high, it denotes inflammation. Other factors that may denote inflammation, like as you see in this title, GDF-15, which is gross differentiation 15. I'm not going to discuss any non-practical information. So up to this point, I clearly show the definition of anemia and the harms of anemia and the benefits of anemia management. And then I summarized the pathogenetic mechanisms of anemia in chronic kidney disease into correctable, potentially correctable, and non-correctable factors. And then we tried to go through iron. To treat with iron, I should know first what is the state of iron stores. If you find absolute iron deficiency, this is a clear indication for iron therapy. If you find the functional iron deficiency, you may give the patient trial of iron. So this is one of the new articles that shows the evolution of iron strategy in management of CKD associated anemia. You can look here in the early 80s, you'll find here oral iron. So oral iron here, oral iron since 80s, and then intravenous iron dextran. So in early 80s, what we have, ferrous sulfate, for example, and iron dextran intravenous form. And then through the years, you'll find different parenteral forms like ferrigluconate, sucrose in the 2000, fluroxetine in 2009, and in 2013 ferric carboxymal dose. Then in 2014, this is the era of ferric citrate to be used as phosphate binder and to control anemia in the same moment. And last year, in 2015, they found that iron may be added to the dialysate in the form of ferric pyrophosphate citrate, and this is a new source, a new route for treating iron deficiency. And it is seen that it will be in the future the treatment strategy in dialysis because it is more physiological. So if you look at this map, you will know the evolution of iron through the years. So what can we use iron? First, look at what is available in your country and use it according to the pharmacokinetics and pharmacodynamics of iron. So the first step, iron is very crucial, but I should know, am I dealing with absolute or non-absolute or iron overload state? Suppose that you find ferritin 500 or 800 and transferrin saturation 40%. I'm not going to give iron. What I give, I can give erythropoiesis-stimulating agents. Okay? So the first stop here, I have 3 categories of patients: chronic kidney disease, hemodialysis, or peritoneal dialysis patients. What form of iron I can give to these patients? Oral or parenteral? If we take them one by one, for chronic kidney disease non-dialysis patients, which is the best, oral or IV iron? This question. Oral or IV for chronic kidney disease. If you have a patient who is creatinine 2 milligram per deciliter, estimated GFR 45 milliliters per minute, you will give him parenteral iron or oral iron? Oral or parenteral? Why oral? If you say parenteral, why parenteral?
What's the difference between oral and intravenous? That's a question.
So if the patient is dialyzed by peritoneal dialysis, oral or IV? If the patient is hemodialyzed or maintained with hemodialysis, first of all, when you decided to give the patient to oral, and this is for CKD without dialysis. So if I have a patient who is just CKD, not dialyzed yet, what I give, I should start with oral iron. Why? Because there is a randomized controlled study that I present to you. When they compare oral versus IV in chronic kidney disease, they found that IV iron is associated with excess hospitalization, excess infection, excess cardiovascular related problems. So I should start with oral in chronic kidney disease non-dialyzed patients. And then, if I give the trial and there is no response, I shift to parenteral iron. This is the standard of care. What is the pitfall in iron and oral iron therapy? It's not only if you have, for example, ferrous sulfate, you will say, I give him 1 tablet ferrous sulfate. We don't know this. The treatment of oral iron depends upon giving 200 milligram elemental iron per day. 200 milligram elemental iron per day for 8 weeks. Either the patient intolerate or side effects of care or the gastrointestinal troubles or resistance to the action, no response. These are the indications to shift after If the patient tolerate, I continue for 8 weeks. After 8 weeks, if no response, I shift to parenteral. That is the wisdom. But don't forget, we give 200 milligram of elemental iron. If you look at this slide that shows the forms of oral iron, ferrous fumarate, gluconate, sulfate, and these are the different forms. And this is the tablet strength or capsule strength. So for example, here in ferrous sulfate, 300 milligram ferrous sulfate has 60 milligram elemental iron. So to get 200 milligram from this strength, you should give 5 tablets. Okay? So we should give the equivalent to 200 milligram elemental, irrespective to the concentration of the capsule or tablet. So when I read the capsule or the form, I should ask myself, what about the elemental content, iron content in the capsule or tablet? And what I recommend and I prescribe is 200 milligram elemental iron for 8 weeks. If the patient intolerates or there are side effects or no response after 8 weeks, this is an indication of parenteral iron. Regarding the parenteral iron, these are the different available forms. And for each one of these parenteral form, you'll find the maximum dose and the protocol of parenteral iron. You should follow the protocol. So first of all, we should diagnose absolute iron deficiency. If we document absolute iron deficiency, I ask myself, what is the type and the kind of patient? CKD without dialysis, start oral. If no response after 8 weeks of adequate dose of elemental iron, shift to parenteral. And then if I use parenteral, I use parenteral by each form strategy. And then I follow serum ferritin and transferrin saturation to check out the adequacy of iron store. And when I replete the stores, I give the patient maintenance dose to keep the iron repleted. I'm not going to discuss the different randomized controlled studies to allow the time for practical points. This is one of the studies showing different form of iron and the comparison. This is the effect of liposomal. This is a smart slide, smart study. Why? Because in the gut there is maximum absorption capacity. Here they changed the technology of iron from the ordinary iron to liposomal iron. And in this study they proved that liposomal oral iron has the same efficacy like parenteral iron. So it seems that the new technology may help a lot in the treatment of anemia. This is a randomized controlled study that showed that oral iron is devoid of the side effect of parenteral iron. Again, serum ferritin. I'm not going to. And this is one of the most recent publications about the toxicity of iron and the labile iron. And the labile iron lead to oxidative stress, lipid peroxidation, DNA damage, and all these side effects of labile iron because it leads to toxicity of mitochondria. And and these are the different forms of parenteral iron and their capacity for oxidative stress, as you see. So we should be cautious when we give iron not to overload the patient. Again, we have cut-off point of hemoglobin. Below it, we diagnose anemia according to age, gender, and whatever the classification you like. Then we should think of the factors that may lead to anemia, and we should treat anemia. And treatment of anemia depends upon what we have: iron, ESA therapy, blood transfusion. We should combat blood transfusion, so we should start with iron and then the ESA therapy. Before giving iron, we should be sure that the patient needs iron, because if the patient has iron overload, no need for parenteral iron. If there is iron deficiency, I correct the deficiency. In CKD, I give oral, then shift to parenteral iron if there is failure or intolerance for oral iron. If the patient on the hemodialysis, we know that the absorption is so bad, bioavailability is so bad, and the oral iron will increase gastrointestinal complications, side effects. So this is why in hemodialysis it is recommended to start with parenteral iron. We have a strategy to look at the iron stores, serum ferritin, plus transferrin saturation should be checked before and periodically to assess iron stores. If we have the capacity in our lab to monitor hypochromic red cell, it may be better. Regarding ether therapy, these are the different forms of ether therapy. And instead of discussing all these lines, we have 3 types of ether therapy according to the duration of action. We have short, and short-acting ether therapy include ibutine or Ebrix. It is for the Jensen Lab company, and the other form is ibutine beta from Roche company. These are the short-acting ether therapy. Intermediate-acting therapy from Amgen, darbutine. And then the last is the sera, continuous receptor activation, erythropoietic receptor activation, which is produced by Roche. So these are the 4 original ESA therapies that are available everywhere. And then we have biosimilars and others, and I'm not going to discuss these with you. And this slide shows that there are many advances to use EPO receptors, hypoxic therapies, antibodies agonists. I'm not going to. What are the differences between ether therapy? If you can say to me, we don't have in our country except ibutine, which is Ebrix. Perfect. Use it. The difference between ether therapies, one of the differences is shown in this slide. If you have ibutine, you should put it always with ice or in the refrigerator. The ibutine beta can stay 5 days out of refrigerator. Alpha, darbutine 7 days. Sera can stay 31 days outside the refrigerator. But if you use it, you should use it. What about the dosage? According to the form you have. If you have ibutine, this is the dose recommended. 50 to 100 units per kg, administered either intravenous or subcutaneous 3 times per week. So this is short acting. And this is for ibutine alpha or beta. For darbutine alpha, the dose is 0.4 to 5 microgram per kg, single dose weekly, subcutaneous or intravenous. And these are the doses for initiation of treatment. Because in the maintenance, I may change the schedule, giving, for example, ibutine once weekly or twice weekly, and darbutine one every 2 weeks, according to the maintenance treatment. Sera in the initiation phase given every 2 weeks, and in the maintenance phase, it is given once monthly. So this is a recommendation to start, and then in the initiation phase, we should monitor hemoglobin weekly, and in the maintenance phase, we monitor hemoglobin monthly. We don't like big variation in hemoglobin. And we like the hemoglobin to increase by 0.5 gram per week. So the maximum accepted rise of hemoglobin is 2 gram per month. I'm not going to discuss some of these. I can convert. Suppose that the patient traveled abroad and was treated by any product of these companies. I can change from short-acting to intermediate-acting to long-acting, so long as I respect the equivalent dose. Okay? Very simple. I can divide the short-acting by 200 to know the dose by darbepoetin, and 270 to know the dose by the serum therapy. Again and again, which is the therapy to be used? The answer of this question comes from this Cochrane group that included 56 studies and 15,000 patients. And this study showed that actually there is no difference between all the available ether therapy. So I want an answer. Which type of ether you recommend? I recommend the available product. So I recommend the available product, and according to the company deal with you. If the company say, for example, to your hospital or to your center, for each one patient treated by my product, I give you free treatment for another patient. It's okay, it's very good, as long as you deal with any of the products of original ether therapy. Okay, I'm escaping this because this is the same information. This is from the new. Okay, what are the precautions before giving ether therapy? So, when I shifted from iron to ether therapy, I mentioned that we have different products. The best product is the available product. This is the answer. And how to use the dose? I mentioned the dose of initiation. How to monitor weekly hemoglobin in the initiation phase and monthly on the maintenance phase. Then, before prescribing ether therapy, we should take proper history. Suppose that your patient has stroke, suffers from malignancy. I'll be cautious in giving erythropoietin for these patients. And I can stop at certain level of hemoglobin. Instead of 11 gram per deciliter, I can stop at 10 gram per deciliter because there is a risk of overcorrection. So this is why we should look at these suggested contraindications or precautions that include previous history of thrombotic vascular event in the past 6 months, myocardial infarction, cerebrovascular accident, transient ischemic attack, DVT, pulmonary embolism. So I should ask about all these factors. I met a patient in the outpatient clinic treated with serum while his hemoglobin is 12 and he just recovered from stroke. I never give him erythropoietin or ether therapy in this level of hemoglobin. Previous history of seizures, uncontrolled hypertension, risk factors predisposing to thrombosis, hypercoagulable disease, cancer diagnosis. So I should look at these factors. I consider them precautions. And in this slide, according to this reference, these are suggested contraindications for the ether therapy. These are the adverse effects, the same. But my question to you, why the use of ether therapy is associated with slightly decrease in dialysis adequacy? Why? How to think in the answer in this? Why when I use ether therapy to treat anemia and hemoglobin improves, dialysis adequacy decreases, and I need to improve and increase dialysis offer to the patient? Why? Why? Pourquoi? Because when I If you know the mechanism of dialysis, the dialysis is a process that extracts toxins. If I extract uremic toxins from water, it is easier than cells. So if I'm dealing with anemic patients, suppose that hemoglobin 7 gram per deciliter, this means that plasma is 93% and the red cells is 7% or the cells is 7%. Hematocrit 21% in this scenario. And 80% is plasma. And if hemoglobin increases to 11, hematocrit increases to 33, and so plasma will be 66 instead of 80%, and the rest is cells. To extract toxins from cells, it takes time, and it's more difficult than extraction of toxin from water in the plasma.
So it is the viscosity.
Yeah. Not only the viscosity, but the cells. Yeah. Pure cell aplasia is related to the product, the manufacturer, and currently it is very rare. This is a nice slide because it shows that if your patients need larger doses of iron or larger doses of ether therapy to control anemia, this is a patient with inflammation, and you can predict increased hospitalization and mortality. Okay, so the treatment of anemia, chronic kidney disease, and dialysis is just iron and ether therapy. Do we know any adjuvant treatment? Do you have any idea about adjuvant treatment for hemodialysis associated anemia? Yes? You. So long as you hold the mic, you should answer.
They have vitamin B12.
Which?
Vitamin B12.
B12.
Which else?
Because we found for those patients.
So, look at the Kidugo recommendation and read it regarding the adjuvant therapy. Please read this slide. Yeah.
Not using androgens.
So in the past, we are accustomed to use androgen, like nandrolone. They can wait to support anemia management and to use lower doses of ether therapy, because in the beginning, ether therapies were so expensive. So we have a study here, and we don't prove the safety. We prove that there are side effects of using androgen. And in the Western community, they recommend against use of androgen. So we don't recommend androgen. But if you are obliged and you don't have resources, you can use it for elderly men, but monitor plasma transaminases and to take care of prostate malignancy. So it is very cautious, and in the Western community it is contraindicated.
Can I say?
Yes, please.
For adjuvant therapies, we have to look for the nutrition.
Yes.
This is most important. Sometimes we are not.
And before nutrition, dialysis adequacy. If you and I discuss these factors in the resistant sectors. So, regarding the other adjuvants, like vitamin C, vitamin D, although from the path of physiological mechanisms, they may help. But what happens in the clinical practice, they don't help anymore. So they suggest not to use all these in the management of anemia. So there is no evidence that any of these adjuvants can help anemia management. I'm not going to stress more on these studies. This is new innovation in the management, which is hypoxia, because they prove that hypoxia stimulates erythropoietin release. Hypoxia stimulates iron release from reticular endothelial system. Hypoxia increases absorption of iron. So by this way, it improves and can treat anemia management. And this is one of the advances, is to use oral, the hypoxia inducible factor stabilizer, which inhibit pyrrolyl hydroxylase enzyme, so it stabilizes the hypoxia inducible factor, is very interesting. Why? Because it is given oral, and this study shows that this drug, this one of the drugs from this class, roxadustat, can be given, as you see the number of patients, and I'm not going to distress upon that. Now, so the treatment of anemia in chronic kidneys and dialysis, iron, ESA therapy, and the most important adjuvant treatment is iron. Again, iron and iron and iron. And if you document vitamin B12 or folate deficiency, you should treat deficiencies. If you document L-carnitine deficiency, you should give the deficiencies. But if you say, I give this as an adjuvant, it is not, it is without any evidence. And then the new era may be hypoxia inducible factor stabilizers, but it's not available yet in the market. Regarding the most important economic question, how to reduce the cost of treating anemia? By optimization of the use of what is available. One of the optimization, even if you have just erythropoietin alpha, which is known as Ebutin or Ebrex, whatever the name, instead of giving it to the patient intravenous, give it subcutaneous. And this one of the studies included 60, this is 5,057, 62,000 patients in the United States. And the use of subcutaneous route reduces the dose by 25% to 30%, and in the same moment there is no added side effect. Even the side effect profile is better with subcutaneous route than intravenous. So in our countries, we recommend subcutaneous route for erythropoietin because it will reduce the dose. If it reduces the dose by 25%, instead of treating 3 patients, I treat 4. So for each 3 patients treated, 1 is treated free of charge. Non-pronodical weight, which is androgen, this is our study, but we don't recommend it. The new era of ferric citrate, I know ferric citrate is not available in all countries, so I'm not going to discuss, but ferric citrate can help us in 2 issues. To treat chronic kidney disease mineral bone disorder as a potent phosphate binder and replete the iron stores. I'm going to skip all these. If you treat the patient with erythropoietin or ether and you have resistance, there is no response, you should think of the etiology of resistance. And the etiology of resistance here may be because of bleeding, hemolysis, deficiencies, hyperparathyroidism, inflammation, malnutrition, use of the drugs, etc. At the end of the day, may be absolute resistance because of bone marrow fibrosis. I'm going to skip all these. The dialyzer doesn't affect, although this is a new study showing that hemodiafiltration with online hemodiafiltration with high volume may improve the ESA resistance because it gets rid of or increase the clearance of all metamolecules, plasma hepcidin, and inflammatory markers. Ultra pure water is important, but it's very expensive, and this is why I'm not going to discuss it anymore. One of the practical points, although it was published in a case report, is don't forget, if the patient is transplanted and then suffered from graft failure, that the graft is still there. So, if you treat anemia and the patient responds, and after a while there is a resistance, and there is a graft in situ, think of inflammation related to the presence of the graft. request C-reactive protein. If you find it high with anemia, resistant to treatment, this is an indication of graft nephrectomy. So this is maybe a cause. At the end, if you cannot get rid of the factors, we should avoid blood transfusion as we can. But if the patient has severe anemia and is symptomatic, you may be obliged to give blood transfusion. Variability, I'm not going to discuss these details because I know that you are fully saturated. But when you think of blood transfusion, put in your mind that the patient may need in the future renal transplantation. So you cannot say, if the hemoglobin is 10.5, I'll give blood. No. You can wait and assess the patient hemodynamic status. But don't leave your patient with hemoglobin 4 gram per deciliter with anemic heart failure. This is because of medical-legal aspects. I leave the malignancy for your questions. And then the last question is target hemoglobin. What is the target hemoglobin? And when I treat the patient with CKD associated anemia, which target I should seek? 10, 12, 13, 14, full correction.
11.5 to
Okay,
12.5.
let us discuss it together. Here we don't treat for figures. We treat a patient because a good doctor treats disease. A good doctor treats disease, but the major or great doctor treats a patient. So the best issue is to achieve these clinical endpoints, to improve survival, quality of life, to retard the progression of end-stage kidney disease, or to give the treatment. So the target hemoglobin is in the bottom. So in the middle you may give just treatment to avoid blood transfusion. So it is not a sharp figure to be followed, and according to the patient characteristic, but generally above 10, we need hemoglobin to be 10 or above. And if the patient age is 75 or more, or 85 or more, 80 or more, I may stop at 9 or 9.5. So if the patient is younger, I can raise hemoglobin to 11. And if it's older, I can, 9.5 may be sufficient. So according to the patient characteristics.
You can say that there is a fixed figure for hemoglobin.
From 10,
it's variable according to
the patient characteristics. So, and it is sufficient to say from 10.5 to 11.5. If your patient is in the old age, be on the 10.5 side. If the patient is young, be on the 11.5 side.
also have to consider any past history.
Yes, of malignancy, stroke, etc. Yes. So in the past, since this is 2014, the target hemoglobin was in the green area between 11.5 to 12.5. If it's above 13, it is red, harmful. And below 10, it is harmful. And in the area between 10 to 11 or 12.5 to 13, it is gray color. Currently, the target is just a little bit lowered from 10.5 to 11.5. This is the age. This is the scenario because I mentioned that there is a mobile iron. If you give the patient iron in excess, they may be harmful. If you read in the European practice guidelines, they stated that if you have sepsis, this is a contraindication for parenteral iron. Why? Because parental iron may be in excess and lead to depression of phagocyte function. So this is why from the European practice guidelines, stop iron in the presence of sepsis. But it is challenging in this study. Although I don't suggest or recommend, so long as you have adequate hemoglobin, to give the patient parental iron in the presence of active infection until the guidelines is changed. This is the last slide from the JAM. We have limitation of our knowledge, but we should read and we should be updated. And every day we have a change in medicine, because medicine is changing every minute. So we should read, we should be updated, and be humble about the limitation of literature we have. And this is the last quotation by Edward Deming, who stated that it is not enough to do your best. You must know what to do and then do your best. Thank you very much.
Thank you, Professor Hussein, for this urgent presentation about a very important subject, and all of us facing this problem of anemia with CKD. And now we will open the discussion. Any question from the floor?
Yes, please.
Please go ahead.
لا أصلا ما يكتب.
Thank you so much for the presentation, Professor. It's very nice.
Thank you.
It's just a clarification. What did you mean when you said that the dialyzer has no effect on the anemia? Is it the type of dialyzer or the size of dialyzer?
Thank you very much. Because you may find doctors saying that you use low flux. This is why your patient is anemic. There is no evidence that if you use high flux, this will improve anemia management. So this is why I meant to buy the type of dialyzer. But if you use bioincompatible membrane and it's associated with inflammation, it's active protein, this is may guide to use polysulfone, for example, biocompatible materials. So by the type of dialyzer, I mean low flux or high flux. So there is no good evidence showing that high flux use is associated with better anemia management. But maybe indirectly through the use of ultra pure water and low inflammation. Yes? Yes?
Thanks for this elegant lecture as usual, Professor Hussein. And many, many thanks to give us chance to attend this basic course. We know that multiple myeloma is a common problem in patients with end-stage disease, and many of them complicated with iron deficiency anemia due to bleeding and abscess. How to manage such patients? And we give this in this patient? If yes, how? If you don't, how to manage the
I think you asked me this question before. Am I right?
You need to get the answer.
So, if you ask me this question before, review the videos. So, we skip multiple myeloma because they take long time to explain. Okay? Leave it just as a side issue. Because I omitted some slides about hematological malignancies, including myelomas, myelodysplastic leukemias, etc. I don't like to go in these sideways. Okay.
I just wanted to commend you as an institution. When we went to the one, I was very, very much impressed. I think the lowest HB I saw there was about 8.5. So to be managing chronic patients with those very nice HBs, I think, like your presentation shows, you are doing a lot of institution.
not the point actually.
So you can repeat it clearly, just in a simple manner.
The point wants to.
It's just the point of commendation.
Recommendation?
Commending the institution, congratulating the institution. Because when we went to the ward, I think we found that a good number of chronic patients have been managed there.
Yeah.
But the lowest HB that I personally saw was about 8.5.
Yeah.
Most of them were above that.
Yes.
As an institution, you are doing very well in this area of anemia management.
Okay, thank you. Thank you.
I think Dr. Hussein, I want you to stress about we have to avoid rapid rising, rapid increasing.
This is one of the slides that I omitted, and I mentioned this Friday.
Okay.
Because as I said to you, I omitted 75 slides. There is one article that was published yesterday online, reviewing the anemia management from ether therapy, the ether therapy recommendation from a review article. One of the key points in the recommendation is to avoid the rapid rise of hemoglobin because it's bad. Rapid rise and rapid decline means that you have big variation. And this is one of the sectors that even I go through rapidly here. Although when I reviewed variations, I find the evidence is not strong toward the association of variation with the outcome. And when I presented a lecture since 3 years about hemoglobin variation, I said to the audience, do you agree that variation affects the outcome? All of the audience said yes, and at that time I said no, there is no evidence. But currently, it is very bad from the management point of view. Is to find hemoglobin today 8, tomorrow 10, and the day after 7. This is very bad, up and down. So we should, if we say 10.5 to 11 is good for this age, 11 to 11.5 for this age, you should strive to have your hemoglobin between these two values. And don't allow big oscillation of hemoglobin. So rapid rise is bad, and big variations are bad. And they are not associated with the type of ether therapy you use, but it is associated by the good of the quality you follow. So if you monitor hemoglobin well, and you have that chart, and look at the serial reading, this is a way to avoid these big variations. And some centers depend upon clinical pharmacists or even an anemia nurse to follow exactly the figures of hemoglobin and the dose of ether therapy. And there are publications showing that depending on clinical pharmacist or anemia nurse affects beneficially the anemia management. So I agree with you. Big variations are bad. Rapid rise of hemoglobin is bad. So we put a target for us when we start anemia management is just 0.5 gram per week.
Yeah, in the same direction, how frequently will monitor hemoglobin on initiation and maintenance?
So when I start with the recommended dose, I should follow the hemoglobin weekly. And if I find that the hemoglobin is increasing by rapidly, I can decrease the dose. And when I reach the target, suppose the target is 11, and hemoglobin today is 11, I can increase the frequencies, but I should put my eyes to avoid the big oscillation. So I can start, for example, with 4,000 ibutine, which is a short-acting, 3 times weekly subcutaneous, and then with the follow-up, I may reach 2,000 twice weekly. So according to the patient.
If you don't mind the titration of the dose when you reach the target, how will proceed? Either will stop directly or
according to the rise of hemoglobin. If it is very big rise and you are annoyed by this, you can even stop temporarily. But the wise way So if you have acceptable rise, you can just handle the dose. If you have very rapid rise, you can stop temporarily to avoid rapid drop of hemoglobin to 12.5 or 13 gram per deciliter, because it may lead to catastrophes, hypertension, severe hypertension, fistula closure, thrombotic events, and these are the bad side of ESA therapy or anemia management. So we should be rational. We don't totally correct hemoglobin deficit. We treat the anemia partially. And the partially is to reach the target, because 10 to 12 to 11 is not the target, it is not the normal hemoglobin. And if you just remember the first slide, the cutoff point for anemia in adult males, if hemoglobin decreases below 13, and I never recommend treating anemia in CKD to the level of 13 gram per deciliter, because it is really harmful.
So what's the priority?
And one point, please. Sorry for interruption, but one point which is interesting for all our countries of limited resources. Do you know that if I come here and then saying that we should have target hemoglobin of 13 instead of 11, this means I increase the level by 2 grams, this equals multiple $1 billion for the company interest. So the cost is very important and crucial.
Merci, professeur.
Merci beaucoup.
Je voulais poser la question à propos des patients qui sont des patients drépanocytaires. Parce que chez nous, au Congo, disons en Afrique noire, et même je crois jusqu'ici en Afrique du Nord, il y a pas mal de patients qui sont drépanocytaires. Et donc, les objectifs que vous donnez, 10 à 12 ou même 11, est-ce que vraiment on peut les appliquer chez les patients drépanocytaires, en sachant que lorsque nous mettons les ACE, nous augmentons la dose, nous augmentons la dose des hémoglobines, des globules rouges mal formés. Donc, et qui entraîne plus de thrombose, etc., etc. Alors, est-ce que ici, il ne s'agit pas de prendre un niveau plus bas?
Okay, thank you very much. Here, the best answer is I don't review trypanosomiasis associated anemia, but I have 2 points here. Number 1, is it trypanosomiasis plus chronic kidney disease, or just trypanosis? This is 1 point.
Non, je ne parle pas de la trypanosomie, je parle de la drépanocytose. Cyclémia, la malformation génétique de l'hémoglobine.
Sickle cell, yes. Yeah, very nice question. Let me to tell you our story with sickle cell disease. When we visited Nigeria, we stayed in the sickle cell center. So I know sickle cell, and we transplanted a case of sickle cell anemia in this center. And this was a very nice lady, pharmacist, with severe anemia. So, if we give ESA therapy, this means that we will increase the sickling process, and this will increase sickling crisis. And to the point that even after transplantation, and I will not give her erythropoietin, but I'm afraid of the natural erythropoietin produced by the kidney transplant. So we were afraid. And when I reviewed the literature, and this was in 2001, since 15 years, I found a series of transplantation of sickle cell disease nephropathy cases, 83. But the publication was from the surgical aspects, graft survival, patient survival, and they didn't concentrate on the medical aspects, how to control anemia. And before transplantation, how to look at the cross match. Because this is, if you transplant an anemic patient by severe anemia, you may lose this patient in table. So we should improve anemia management. So what we did in this case is, we sent consultation for experts, and the answers were unsatisfactory. So we looked at all publications in doing surgery for a sickle cell disease patient. And the recommendation, for example, if you have a patient with sickle cell disease and the patient's condition necessitate cholecystectomy, for example, you should give the patient hemoglobin A before surgery to increase the level and dilute, to increase hemoglobin A and to dilute hemoglobin S, to avoid what you mentioned, because the patient in surgery may develop hypotension, hypovolemia, hypoxemia, and all these factors can lead to sickle crisis. And the sickle crisis, as I mentioned, may be hemolytic, may be pneumonic, etc. So what we did, we applied a protocol on dialysis to give her 2-unit blood transfusion each dialysis session, so 6 unit bloods, with the use of leukocytic filter. And we repeated cross-match immediately after the last bag. And we transplant the case after diluting hemoglobin S. And after transplantation, we continue giving her hydroxyurea. Because hydroxyurea led to shifting from hemoglobin S, that if you leave the RBCs will be S, to hemoglobin F. And by this way, we have the case transplanted with, and even she was married and have delivered the baby after transplantation. But she complained of a lot of bone crises, osteonecrosis of the femoral head and the humeral head, and eventually she died with graft failure, but after 13 years and enjoyed the delivery of a baby. So working with sickle cell nephropathy, it is very difficult and need an expert. And we may not recommend these levels, but we should avoid blood transfusion as we can. We can use hydroxyurea. And one important point specifically in sickle cell disease, we should think of vaccination, or at least continuing antibiotic, to avoid the complication of asplenia. Because this patient may suffer from autosplenectomy from crisis in early childhood. I'm not if this is a second or not. Again, in sickle cell disease, this I review this level. I can select 9 gram per deciliter is enough, and I may use iron only to avoid the use of ether therapy. So here I should individualize my treatment according to the patient characteristics.
That's why we said there is individual targets for some individual patients, including the sickly patient.
I just want to say to you that the expert on the Medscape, if I show you the reply, this is not at all. This means that he doesn't know. Okay? I think it's enough. And we will meet again. At the hotel, we will move by 7:30. So you can go to the hotel for 1 hour or 1/4 hour, and we will meet the dinner at 8 o'clock. Okay? Thank you very much.
Thank you very much. Thank you, Professor Hussein.
So, and this is the, here I just want to appreciate the presence of Professor Ahmed Rabia. He is the Chief of Internal Medicine Department at Al Munufia University. Thank you very much.